Welcome to the next webinar in the BHI Collaborative's Overcoming Obstacles series, Sustaining Behavioral Healthcare in Your Practice. This webinar is titled, Assembling the BHI Care Team, Roles and Responsibilities. Before we get started, please note this webinar is for informational purposes only. Please consult a professional advisor for specific medical, legal, financial, or other advice. If you have any questions or concerns, please send your inquiries to practice.sustainability@ama-assn.org. This series is a collective product of 8 of the nation's leading physician organizations dedicated to equipping physicians and their practices with the necessary knowledge to sustain a whole person, integrated, and equitable approach to physical, mental, and behavioral health care during the COVID-19 pandemic and beyond. This webinar will cover how to identify your practice's behavioral health needs and train, as appropriate, current staff to meet the behavioral health needs of your patients. Experts will also share how they have gone about identifying qualified candidates for their care team roles and what qualities they have found that's the most valuable. Joining us today are Dr. Sarah Coles, Program Director for the Family and Community Medicine Residency at North Country Healthcare in Flagstaff, Arizona, and Associate Professor in the Department of Family, Community, and Preventative Medicine at the University of Arizona College of Medicine, Phoenix. We also have Jennifer Schwartz, Behavioral Health Program Manager and Therapist at the Corner Health Center in Michigan. And with that, I will turn the conversation over to you, Dr. Coles.
Thank you so much. And thank you everyone for joining us today. I'm very excited to get to be here to talk to you about something that is near and dear to my heart, which is behavioral health integration in the collaborative care model. So I'm thrilled to get to talk about how do you assemble that care team, the roles and responsibilities of members of that team in our collaborative care model. Next slide, please. I do not have any disclosures in relation to this presentation. Next slide. The learning objectives for my portion today would be to identify roles and responsibilities of members of the collaborative care team, to discuss strategies to recruit and maintain collaborative care team members, and to increase your confidence in successfully implementing collaborative care model in your practice setting. Next slide. So the first thing you need to do when you're building your team and thinking about the collaborative care model is identifying the need. Why do we want to do this and put in the investment of time, energy, personnel to build this kind of a model? And the need is readily apparent and frankly quite obvious. We know that primary care providers prescribe about 79% of antidepressant medications and see more than half of the people being treated for depression in the United States. We also know that about half of people referred to a mental health provider don't follow through for a number of reasons, including significant barriers and challenges that they face. And 80% of those who do are only seen once. So there is significant need for additional access for patients in primary care and behavioral health space. We know that depression is a leading cause of worldwide disability. And in my state, the state of Arizona, only 40% of adults with a mental illness receive any form of treatment, and the other 60% don't receive any at all. We also know that this is a challenging thing to treat, that most people need at least one change in their treatment plan in order to achieve remission. Next slide. So let's think about who gets treatment and go ahead and click next again. And you're going to see that if each of these faces represents about 10% of the population, maybe 20% are receiving care from their primary care provider for mental health disorders. 20% are receiving mental health care from a mental health provider. And 60%, as I said earlier, aren't receiving any care at all for their mental health illness. This is a real challenge and something we wouldn't tolerate in any other area of healthcare. What would we feel like if this were cancer care patients or heart disease patients? And there's no reason to treat behavioral health needs any differently. Next slide. But fortunately, there's a very good solution to this, and that's the collaborative care model. We're going to talk more about the model and how you build your team in just a moment. But we know that collaborative care is a really wonderful solution towards achieving the quadruple aim. We know that collaborative care increases access to care, improves outcomes, decreases cost, and improves the patient and provider experience. Next slide. So what is the collaborative care model? This is a systematic approach to common mental health conditions that are seen in the primary care setting that integrates a psychiatric consultant, a behavioral health care manager, the PCP, and most importantly, the patient. This is truly an integrated care model, not a co-located or even just happenstance nearby kind of a model. This allows our teams to work in collaboration to provide better care to the patient and for each other. And so it allows all 4 members to really collaborate and work together. The patient, who of course is the center of the team and drives all of the care by setting goals and objectives for treatment. The PCP, who diagnoses and manages the care. The psychiatrist, who provides consultative recommendations. And the behavioral health care manager, who is frankly the glue of the team, who does many things, which we'll talk about in just a moment. Importantly, the behavioral health care manager manages a registry of those patients that are enrolled in this particular program to help us easily identify who needs further assistance and make rapid adjustments in care treatment plans. Next slide. So the patient's role is to be the patient, to choose treatment and identify goals. They are the center of all of this, and they are really the person who drives everything that we do in a collaborative care, or frankly, any care model. The PCP continues to be the PCP. They're the primary provider of all of the care. The psychiatrist provides indirect care through consultation with the care manager, review of the notes, and direct communication with the PCP as well. The psychiatrist does not typically directly see the patient themselves. It's possible, but it's typically not a part of this model, and provides recommendations to the PCP and care manager to help us improve the care we're providing. The care manager does a lot of stuff. There is no shortage of stuff that the care manager is doing. They really are the glue that kind of seeps through all of the cracks. The care manager coordinates the behavioral health care, performs initial assessments and systematic follow-up of the patients. They provide education, they help with medication management, they update treatment plans, they can perform brief psychotherapy depending on the type of specialist or licensed individual you have providing this care, and they complete the majority of the documentation. The care manager also completes the majority of the communication between all 4 members of the team. Next slide. Collaborative care works on several core principles. The most important one in the collaborative care model is that it is patient-centered, team-based care. This provides care in the patient's familiar setting, their primary care medical home, where they can feel comfortable and decrease stigma. Importantly, it incorporates patient goals and their choice of treatment into the plan. This is meant to be a true collaboration with all members. And we directly collaborate between all parts of the team and share our care plans with each other, so no one is in the dark and we're all on the same page. Collaborative care also provides population-based care with a defined group, a cohort of patients who are tracked over time using an electronic patient registry. The registry is really important because not only does it allow us to quickly track patients' progress and make sure that nobody is falling through the cracks, but it allows us to identify folks who aren't improving as expected and to make real-time rapid adjustments in their treatment plan. It helps make sure that nobody is losing out and everybody is getting care that they need. Next slide. Collaborative care also uses measurement-based treat to target. So we use clinically established evidence-based measures like the GAD-7 for anxiety or PHQ-9 for depression to work to treat towards clinical outcomes. And of course, we want this all to be evidence-based. We use treatments that are backed by credible research like pharmacotherapy and psychotherapy. This allows us to provide evidence-based education as well to our PCPs, included in that consultation note and working with our behavioral health care management, as well to our patient. Next slide. So this is an example of what a registry might look like. And there's several different registries that you could use, but the registry is to help us quickly track how our patients are doing and make sure that everybody is getting the care that they need. So you can see, we can see each patient, their date of the initial assessment, when their contact was, how many visits we've had, their initial scores, their most recent scores, how are their scores doing, as well as psychiatric consultant notes, other case management notes. In our practice, we're also tracking diabetes and hypertension, which we keep on our registry as well. So this is a very convenient and evidence-based way to manage a population and cohort of patients to make sure that everybody is improving as expected. Next slide. This is a very, very minimized workflow to just give you kind of a sense of what a collaborative care workflow looks like. So we start with the PCP and the patient identifying a qualifying mental health disorder, things like depression, anxiety, and the PCP diagnoses and then starts treatment. If needed, the PCP will then refer or intake them into the collaborative care program and provide a warm handoff into our collaborative care manager. In our practice, our care manager is a behavioral health RN, which is why you see that I wrote RN on the screen. So once they're in the collaborative care, they're engaged in active treatment of their mental health condition. They'll follow up frequently with the care manager for assessments, touch points, barrier solution solving, identifying anything that we can do to help. The care manager will also staff the patients with psychiatry to make sure that we're doing all the things that we should be doing and that we're not missing anything, or if something's not improving, to get recommendations for what we could be doing differently, and then communicates with all members of the team. Once the patient is improving and hits their identified goal for care, we can move them into relapse prevention and monitoring phase of the care. And then once we get to a good place where everyone feels comfortable and safe, we'll graduate back to routine care with the PCP. And this really is meant to be not a forever plan to be in collaborative care, but something that people can move in and out of as needed depending on their mental health needs. Next slide, please. Most importantly, what I want you to take away is that collaborative care works. The time to remission in depression for people who are getting usual care in a primary care setting is 614 days. That is a very long time. But people who participate in collaborative care, the time to remission is only 86 days. So doing this work, working integrated professional teams into your care flow is hugely beneficial for all involved, most importantly, the patient. Next slide, please. So briefly, how we implement this model is you develop a goal. So in our practice, we decided we wanted to implement evidence-based program to improve behavioral health care in our primary care setting. We've researched the models and we very quickly landed on the collaborative care model developed by the University of Washington Ames Center, as this was a highly evidence-based and doable model. Next, you need to build your team, and we're going to talk more about that in just a moment. Once you have your team, you need to create stakeholder buy-in. Everybody in the practice needs to get bought into this model and make sure all of their questions are answered and that their concerns are addressed. You'll develop a workflow, and then you'll do trainings, lots of trainings. This is something that we're going to have to do repeatedly to make sure everyone is on the same page. So you want to train about the rationale, the workflows, how to bill and code for these types of visits, and behavioral health management. Next slide. So building your team is a critical and core step. You are putting together your team of superheroes who is going to do this necessary work for the patients in your practice. And so this is something you want to take the time to do to get right. Because if you put the right team in place, you can overcome any obstacles and barriers, and it is well worth the extra thought and effort to find the right folks. Next slide. So I'm going to tell you just a little bit about our practice so you can see where we're coming from. So I worked at a family medicine residency at the University of Arizona College of Medicine, Phoenix, in Phoenix, Arizona. Our site is this lovely building where we had multiple residencies in the same place. So the family medicine residency, which had 3 office sites in the same building, on-site psychology with some limited availability for our patients, and we already had a large interprofessional practice. And the floor below us was the internal medicine residency program that had 1 office site in the same building as us, but they didn't have any access to behavioral health on site. And we also had the psychiatry residency in the same building that had previously not been integrated in primary care. I will say when I started this work, I had no experience in integrated behavioral health care or the collaborative care model. This was something that we identified that we really needed to do for our patients and then went for it. So this is something that you can do even if you've never done it before. Next slide. So this is our team. So on the left is Dr. Elena Petty, and then Dr. Susanna Wield, myself, and Deborah Castile. Dr. Petty is our psychiatry consultant. Dr. Wield and myself are the PCP managers for our team. And Deborah Castile is our heartbeat and core. She is our behavioral health care manager who runs a lot of our team's work and effort. This is the most important thing you can do, is finding the right folks. And I can say that we were successful in this because we took the time to make sure everyone on the team was the right fit and really believed in this mission. Next slide, and I'll tell you how we did that. So first thing we did was identify champions. Who was somebody who could come in and really own the collaborative care and integrated behavioral health model? We wanted everybody to feel like this was something that was important to them and something that they were going to put the work in. We recruited broadly. We knew that they might not be all the right people in our current staff to do this work. And we were very fortunate that most were, but we did find a behavioral health care manager outside of our already existing clinic members. And she was absolutely the right fit. We wanted somebody who would come in and not only be bought in, but help create stakeholder buy-in and engage all members of the team. And we used behavioral-based interviewing to ask those kinds of questions to identify good culture, fit, and skills. You really want to identify people who are really focused on the mission, who really want to do this right for all of our patients, and you want to seek diversity, inclusion, and equity, because we know we're better when we have diverse voices in the room who are included and participating equitably. We want folks who can creatively problem solve barriers and reinforce and reward successes, because this is a practice model change for many people, and that can be really hard. We want people who are ready to train and train again and train others. And then you want to create a space that allows for psychological safety. We want to be able to disagree with each other, to really lean into that conflict and engage with each other on things that are working and things that aren't working so that we can come up with a better solution. Next slide. So the key steps were mostly what I've already talked about. Once you have your team in place, you want to retain your team in place. So frequent team meetings to review how things are going. We want to reinforce that shared mission at every team meeting and at every touch point to develop a culture of integrated behavioral health. We're going to engage in iterative training. As we said, this is a new practice model and things will come up that you'll need to train and retrain on. We need to be ready to have frequent process changes. You will try something and it won't work, and that's okay. That's totally normal. So you're going to PDSA cycle, plan, do, study, act cycle through this. Try something, document what worked, strengthen what worked, something that didn't work, and make a change and try again. You want to identify both challenges and successes and work across silos. Everybody needs to be involved in this. So include your billers and coders, your EHR, your administrative team, health information exchanges, if you have access to that. Everybody in the practice should be a part of this. And then of course you want to build partnerships with local behavioral health facilities and establish referral patterns. Not everything will make sense to treat in a collaborative care model, and sometimes we do need to refer out. So make sure you have local partners who are willing to help and work with you in that process. Next slide. And it's all about collaboration. So you want to have a champion, as we said, who will help you build workflows to accommodate all needs and goals. Regular communication with an agreed upon format is critical, as well as those frequent touch points. You want to make sure that your team is giving you specific, actionable feedback, and then you act on it. And then tell them what you did and what change you made, and then get feedback on that. And they're reminding everyone that this is a dynamic panel. Things change frequently, and that's okay. And we're going to work together to make sure that we're getting the best available care to our patients and our teams. Next slide. So here's our results as of March 31st of this year. We had 175 people treated in this model, and you can see our depression and our anxiety scores decreased by over half for all of our patients, which is a huge win for our patients. Our patients are really enjoying participating in this model. They love getting to know our behavioral health care manager, who is fantastic, and they feel much more engaged with their PCP as well. Next slide. There are benefits to everybody, as I said. The clinicians have increased comfort with behavioral health screening, diagnosis, and management. It has undoubtedly increased my scope of practice and has allowed me to get more complex cases with support from psychiatry and the care manager. It decompresses the office visit because I might have more time to focus on other things that I also need to address. It's a billable service, which is of course important. And it does allow us to improve the detection of social determinants of health and equity that we might have otherwise been missing and addressing. It allows patients to stay in their primary care home where they feel comfortable and safe. It gives them increased touch points and increased access to both behavioral and other healthcare needs. And it improves their health outcomes across the board. It allows them to coordinate across multiple services to get more resources than they might have had previously, and a safer medication management as well. Next slide. And our clinicians love it. They have overwhelmingly been positive about this experience, letting them expand their practice, take better care of patients, and they get to see how much better our patients are doing in this model, which helps them feel better. We all want to be doing right by our patients, and engaging in this model really does reinforce that for us. Next slide. So here are some resources for you all. Next slide. And thank you so much for listening and this time. Please feel free to contact me anytime if you have any questions. And with that, I'm going to hand it over to Jennifer.
Thank you so much, Dr. Coles, Sarah. I appreciate it. So for the second half of our presentation today, I am going to zoom in just a little bit and get really specific with regard to the role of the care manager. So as Sarah shared with you, this person is kind of the glue that holds the team together, and we will talk about exactly what that looks like. Next slide, please. Okay. At this time, I don't have anything to disclose. Next slide, please. Okay. For my portion today, some of our learning objectives will include a review of the collaborative care model, which Dr. Coles beautifully explained to you already. We'll learn about some examples of adaptations of this model, which are currently in use in some nonprofit settings, right now. We'll also review the primary job functions of the care manager, kind of most importantly, and connect the skills that are inherent to this role to those of job seekers to help ensure a good fit. Finally, we're going to view some examples of coordination documents and tools that might be utilized by a care manager to make this system work. Okay, next slide, please. So as I said, Sarah gave a wonderful and concise description of the model, so I don't wish to belabor the points that she made. But essentially, this is the process that we are talking about, right? This image is directly from the AIMS Center's training materials, their conceptualization of what integrated behavioral health should look like. In this case, of course, traditionally the consultant would be a psychiatrist. However, this model of care is highly adaptive in so many different capacities. For example, one of the clinics that I have served in previously used this model, but rather than making use of a psychiatrist, utilized a transgender care specialist. And we were able to, support the needs of that particular population. So many different specialty populations could be served, utilizing this model. Next slide, please. Okay. So I want to share with you a couple of the adaptations that are at, kind of in process right now. So this image that has been edited just a little bit from its original form represents what care looks like in one particular nonprofit clinic in Southeast Michigan here, right? Okay. So this was a team that I led that consisted primarily of therapists. I myself am a therapist. I'm a clinical social worker and trained as a therapist. And prior to the adoption of this model, therapy had been housed alongside primary care, and we had no psychiatric practitioner on site at all, right? We decided that we wanted to increase the kind of efficiency and flexibility in our clinic, and we sought out this model as a possibility. And by adding a psychiatric consultant, this is kind of what we came up with and how this worked for us. So we stuck to this model with as much fidelity as possible, but we also over time recognized that our kind of main medical provider was so very busy. She's an incredibly talented individual, but she teaches, she sees clients, she has residents and medical students with her with such frequency that sometimes she couldn't make it to our collaborative care meetings. So this is where the registry and communication via our EHR became extremely important, that often the therapists were consistently able to show up and to convey good necessary information about client progress to the psychiatrist. The psychiatrist was able to kind of direct our primary care providers, including not only an MD, but also several NPs in our practice, direct them to prescribe. And even when the PCPs were not available, we had a very nice kind of process flow here. As it happened, our psychiatrist actually never needed to interface directly with clients. All of her work was done through the therapists and then in collaboration with our prescribers. And that worked very nicely for this team. Okay, next slide. This is an example that represents the configuration of my current team, where I lead the behavioral health program at Corner Health Center here in Ypsilanti. I lead a team of social workers, some of whom are therapists, but also we have like case management social workers. We have maternal infant mental health workers, just a variety of different social work roles, right? So currently we have a weekly integration meeting. All of the social work staff is present, and all of our prescribers who also come from a variety of different backgrounds. We have OBGYN, definitely primary care. We have some transgender kind of specialty care on board as well. And then lots of residents, lots of students, and other folks, you know, kind of moving through our clinic because we are a teaching practice. Okay. We also have a couple of NPs on board. So all of these folks show up at this collaborative care meeting, and a lot of this work that normally would show up in a registry is happening in real time, like in communication, that the individual social workers, whether they be care managers or therapy staff, are reporting out client progress aloud. We're tracking them in this integration meeting together, and that information is being conveyed back to the psychiatrist for follow-up. And so most usually, we are either, because we work with adolescents, we're either having the psychiatrist follow up with them directly, or we are just getting kind of the psychiatrist's perspective on, you know, any kind of changes that need to take place, and that is being conveyed back to the prescribers also through the EHR. So no actual registry in place here, but a little more interaction between the psychiatrist and the patients, and then lots and lots of integration and collaboration and work together between prescribers, social workers, and then of course the patient. So in the future, you know, we may look at adding a registry for this team, but at least right now, you know, we are continuing with a variety of evidence-based tools for monitoring that are effective for us. Okay, next slide. So, you know, to kind of move on to our next piece for consideration, right? Like that this model is highly effective, but it's also highly adaptable. One person really that will determine the flexibility and adaptability of your, you know, of your team is that behavioral health care manager. Sarah said, you know, this person is the glue of the team. I would say the same. They are the star of the coordination team. This person is responsible for so many different things that must happen in order for this model to be really, really effective and to give you the efficiency that you're seeking. So we're looking for them to maintain a strong connection between the client and the organization. They are the person with whom the client interfaces the most frequently. They need to be comfortable advocating and communicating on the client's behalf to their medical provider. Again, because we work with adolescents in our clinic, sometimes I have young folks who are comfortable sharing something with me because they meet with me weekly that they might not be as comfortable sharing with a doctor who they only meet with 2 or 3 times a year. So, you know, we are careful about nurturing that relationship and that rapport. They're also responsible for the accurate documentation of client progress so that your psychiatric consultant can make, you know, good, rational decisions about their care. And then of course, really robust recording of client services and communication with the provider in order to drive billing. This is not sustainable for many clinics unless, you know, we see a payoff, sometimes like a literal payoff. And the documentation is really, really the key to that. Okay, next slide. So just to kind of break down what we're talking about, when I'm talking about maintaining a strong connection between the client and organization, I mean that the skills that this person has to have are things like warmth, ability to build and maintain rapport with the client. So certainly I will acknowledge my bias as a social worker. I think social workers are fantastic in this role because of the kind of multifaceted training we receive. But as Dr. Coles mentioned before, of course, RNs, sometimes some public health folks, there are a lot of different you know, kind of backgrounds that might yield someone who's really, really effective in this role. But one of the benefits, in my opinion, of having a mental health provider is someone who has some experience with mental health, that we know what we're looking at, we know what we're looking for as far as screening for side effects and other concerns. We might have some experience utilizing different mental health tools, including like motivational interviewing, behavioral activation, that brief solution-focused therapy that Dr. Coles mentioned, pulling out individual skills from CBT or DBT, also having a really good suicide response framework. Definitely knowledge of that mental health treatment, as we mentioned, and then good soft skills and correspondence, staying up on things with the clients, multiple modes of HIPAA compliant communication. Next slide. Next, we're looking for that person to be able to advocate and communicate well with a medical provider. So that includes good skills of assessment and discernment regarding prioritizing the client's needs. You can't just throw everything at your provider. Of course, you have to help them kind of determine, who's on fire and who can wait for 10 minutes, right? But this also means, to me, proficiency with medical language, as well as good translation between the client and the provider. So ensuring that the client really understands what the provider is asking for them. Comfort and skill working in a team setting, and then those great problem solving skills that Sarah mentioned. Next slide. Again, great documentation is one of the most important parts of this, of client progress. So proficiency with data, knowing how to use an electronic health record well as registry tools, reporting tools, and so on. Making use of mental health assessment skills and tools, having some diagnostic capability is also really, really helpful. I would say speaking the language of psychiatry, if that makes sense. Great example I can provide you. I have watched before my eyes, and seen a therapist and a psychiatrist kind of having an out about what is mania versus what is anxiety. So everyone needs that shared language to make sure that we're being really precise in order to have, good client outcomes. Finally, training in the use and interpretation of every kind of evidence-based tool that you might use, like the PHQ-9 and GAD-7, used in a registry. Okay, next slide. And finally, we're looking for good recording client services for the purpose of really driving that billing. So accurate, detail-oriented. This person needs to be able to, follow multidisciplinary consultation, patient follow-up. Having just a basic knowledge of billing or grant tracking is also very useful. Good time management skills, strong documentation skills. Okay, next slide. Finally, I want to show you a few of the tools that a care manager might utilize in this work. So we definitely want to make use of evidence-based screenings. This is the PHQ-9. This is kind of the standard that the AIM Center has set up. But that said, you can also make use of a variety of other tools as long as they are valid, reliable, and they help to validate your decision making. My team also uses the GAD-7. Okay. I will also say that while these tools cannot take the place of good clinical judgment, they definitely help kind of steer the ship, which is really helpful. Next slide. I also have a few examples here of some registries for you. One is directly from the AIM Center. The other is actually a diabetes registry, from the AMA. As I said before, this model is very effective in multiple kinds of settings. So whether that is, something like pulmonary or diabetes care, something like that, or mental health. Okay, next slide. Okay, and the last thing I would really strongly encourage you do is to create a psychiatric case presentation template to ensure that your care manager can accurately convey mental health symptoms to your psychiatric consultant effectively. So you'll see a couple of the items that I would encourage you to include. And you'll also note that in my kind of resources and references that there are a few links that you might find useful in adapting one for your use or adopting an existing tool. Okay, next slide. Here are a list of just a few resources, including some information on standardized instruments, as well as a psychiatric kind of reference database that you might find useful. Next slide, please. And a few citations of where my work has come from for today. Next slide, please. Thank you so much. Should you have any questions about my portion of today's presentation, please feel free to reach out.
Thank you so much, Jennifer. I thought that was fantastic. And I totally agree with you about how important the adaptability of this model is, because it is such a cool model that works in so many different ways, and that you can kind of adapt and work towards what your practice setting needs or what your patient population needs, because everywhere is a little different, right? Like we all need something kind of different. Which I think brings us to our first discussion question, which is, how has your practice retained folks who are working in this space? Because it is challenging and there is a lot of differences in needs that kind of come up as we're looking through this.
Okay. That is a great question. I would say within the two kind of practice settings where I have worked most recently, one has done a really excellent job in retaining folks. And I would say that is the one that has the strongest fidelity to this model, that they definitely see, as you mentioned, kind of in your portion of the presentation, a reduction in the burden to the whole team, right, in this work. And I think that has had no kind of small impact on especially my mental health providers choosing to remain as a part of the team. Another organization I've worked for has struggled a bit more, and that was the team that lost first and foremost their kind of leader, right? And so without that person, the wheels kind of come off the bus, and they saw much more turnaround all the way across the board, because without the star of the show, other people really struggle to function. So I really feel like that's a strong testament to how this particular model can help you retain staff, or unfortunately cause you to lose them.
Yeah, what a good point about succession planning.
Yes.
You don't want everything to be reliant on one person, because then we really haven't built a successful team yet. We've really put it all on the back of one individual to kind of carry the weight of that program. And oftentimes we have charismatic people in our organizations who can pull that off. But it doesn't work in the long term if they need to leave for whatever reason. One thing I noticed in our practice in terms of integrated behavioral health workforce retention was really building that team and making it feel like team-based care. So really, one, like you've said, the behavioral health care manager, who is the star of the show, should be the star of the show for all of our meetings, for our discussions, for our planning, because this person knows what is going on and what works and what doesn't. And then making sure that all members of the team have an adequate voice, an opportunity to express concern, an autonomy and the ability to create change where they need to, and working collaboratively with each other, and then sharing our successes. I don't know if in your practice, but certainly as a physician, I often will focus heavily on things that didn't go well, rather than on the things that did, and taking the time as a team and a practice to celebrate the good work that's being done, all of the successes, the patient who got better, can be so helpful in keeping people engaged and motivated to do that work. And I don't know, maybe we're just all too hard on ourselves. I'm sure that we're all too hard on ourselves, but it's definitely something that takes effort and focus to do.
Absolutely. Sarah, I wanted to ask you in the middle of your presentation, you had a really interesting, you spent a lot of time and a lot of focus on assembling your team and carefully choosing the right folks. And I think sometimes in this current environment where folks are so understaffed and they are just pulling warm bodies into the mix, you were very, very purposeful about this process. Will you say more about how your practice recruited and trained your staff? And then I heard you also say that you trained and retrained and retrained. So you were really pushing that continuing ed to make sure that these roles remain filled and are functional.
Yeah, and we really did. We're very intentional about building the team. We started before the pandemic, so we had the luxury of not being in a pandemic, which was always nice. But we were aware that this was a major need for our patient population. And like I said, I'm in a residency training center. It was a large academic tertiary care center, but this was still a hole. Our patients didn't have access to behavioral health, and we saw people fall through the cracks, and our providers were getting more and more, not quite burnt out, but really frustrated with the process and the challenges that our patients were facing in areas we felt like we couldn't help. And so we did some research and realized that this was the model that we wanted to engage in, but we also realized it was change, big change to implement this model, and change is hard for everybody. So we wanted to make sure we had the right people in place before we threw in change that would be, challenging for people to adopt to and address. So we spent a lot of time. So our recruitment focused, we started internal, and the first person to be recruited was me. And as I said, I didn't know anything about this. So the first person who also to get trained was me, and spent a lot of time on the University of Washington Ames website, reading through the literature, reading through information on the AMA webpage, the American Academy of Family Physicians, and other organizations that are doing this work, and starting to build that model. The next person we brought on board was our psychiatric consultant, who could really fill in some of the gaps, and started, before we even started the program, started training our PCPs about how to provide mental health care. Because for many of us, it's an area of discomfort, that we don't feel particularly skilled in providing this care, or we're nervous about it. And stigma still very much exists around mental health care, which we also needed to overcome, and to get used to the idea that all healthcare is healthcare, which includes behavioral health. So we weren't body doctors, we were doctors for a whole person. And so we started that. The next person that we recruited was the care manager. And this was who we took the most time to make sure was right, because they are the linchpin of everything. So we started internally, and we didn't have the right folks, either the interest, the champions, or the skill set needed to do that. And so then we reached outside of our clinical setting, into our larger healthcare system, and identified a person who had been working as a behavioral health RN in a local hospital system for a long time, who was amazing and came in and could really kind of bring us all together, have those skill sets and knowledge, and be that champion that we needed. And then we trained, and then we trained some more. So we set up teaching sessions for the physicians about how to provide mental health care, diagnosis, management, and screening. We trained everybody on billing and coding. That took some effort. We trained people how to document this, because it's a different documentation pattern. And then we trained people how to do brief consultative exchange. How do you work with a psychiatrist or a care manager the psychiatrist who's never seen the patient, and the care manager who probably knows way more about the patient at that exact moment than you do? And how do we have that kind of interprofessional team-based training? What did you all do?
That's also, that's a great question. So in both of the scenarios here, I had a staff in place already, who kind of represented the folks who would become the team when this model was introduced. So we didn't recruit from the outside. We kind of trained to fit, right? And there were definitely members of our team who kind of became accustomed more easily, more readily, have a little more flexibility in their practice, and really loved it. And some other folks who preferred kind of a more conventional model of therapy, and that's not wrong. I think, found ways to remain flexible and to utilize both of those services in a way that served the clients well. But I will say one thing that I think we have done, and I would just, pat all of us on the back for, is that we have continued training. So we are bringing in interns all of the time, and making sure that when they complete their field portion of education, that they leave with a working knowledge of this model. And lots of times we can hire them back in, which is great. So we get this great little kind of test run of their performance. We can decide who's going to be a great fit for this model and who we want to keep. And I will say, from my perspective, I almost don't mind hiring folks in that might not have every single one of those skills that I mentioned in my portion of the talk here. For me, it is really that flexibility and adaptability that I look for the most in an intern, and I can teach all the rest of that stuff, right? To the best of my ability, right? So that has been important for us. For the few folks that I have hired from other organizations, like that have come with their own kind of body of training, I am not too proud to say, I've hired a lot of CMHers. I feel like some of them are really rock solid in their mental health knowledge, especially in severe and persistent mental health concerns. I feel like they have great discernment. They really know what they're looking at and what they are looking for from clients. And they seem great with their kind of multi-focus, that they're comfortable, filling a few different roles. So that has been a great source of hires for us. So thank you, CMH. Anything else that you would say for you has been really important about this experience that you would want other people to know if they're thinking about adapting this model for their practice?
Yeah, I think the biggest thing that I would hope to leave people with is this is an excellent model that's highly doable, and as Jennifer said, highly adaptable. You can do this in your practice, in any practice that you are in, and make this work and make this benefit your patients, your team, your communities, really everybody. You don't have to have a lot of experience in this to do this successfully. There are very good resources and tools out there to help you implement this. And I know Jennifer and I are both willing to help too. If you have any questions or things that come up, please feel free to email us. And that this is worth it. We know that patients do better. We know that providers do better, clinicians do better, and communities do better when we do really good integrated team-based care. And the collaborative care model is an excellent example of doing this. I also agree with train. Feel free to teach your teams and keep teaching and keep learning, because medical care changes all the time, and we need to be comfortable with ambiguity and learning something new. And then get comfortable with change management. So it's not going to work the first time you do it exactly out of the box the way you want it to, and that's fine. It's still helping people, and it's okay for it to have little problems that need to be tweaked that you'll work through and solve, as long as you do it together as a team, and it will be very, very rewarding for you to do that. What about you, Jennifer? Any closing thoughts?
Well, I would say absolutely that. I love, that's such a social worky and therapist-y thing to say, that we're not striving for perfection here, right? We're really going for what is good and what is good for everyone on the team. I would absolutely echo you in saying that I think training is and continuing education is one of the biggest parts of this model. For me, that's one of those things that lightens my load, right? That I get a little break from client service. I get reminded of all the important things that I'm doing. I get reinvigorated by, the meaning, the thing that's driving the work. And I see that in my team as well when they get continuing education and continue to train on this model over and over.
Yeah, it's so rewarding.
It really, really is. Thank you so much for having this conversation with me today. Hopefully this will be helpful to others, and absolutely, should people want more information, I know they have great resources here, and folks are welcome to reach out to you and I as well.
Yeah, thank you so much. I learned a ton from you, Jennifer.
Thank you, that's very kind, vice versa.
And Chris, I guess we'll hand it back to you now.
Thank you so much. Wow, just an incredible conversation and some really great insights. Thank you both again for sharing your expertise and experiences with our viewers. I'm sure there are some really great tidbits that folks can use, and really love the concept, right? We're not striving for perfection, but really pushing to really increase access for these desperate needs. So really appreciate your insights today. For those folks that are viewing, please make sure to visit our series page on the AMA website for more information on upcoming releases. You can also access previous recordings on our YouTube playlist. Please also check out the Collaborative's BHI Compendium for a helpful framework on how you can make BHI effective in your practice, along with other actionable resources and practice case studies. Lastly, please access the AMA's strategic practice guides on the AMA's website for implementing specific topics associated with effective behavioral health integration, including pharmacological treatment, substance use disorder, suicide prevention, and broad workflow design. Thank you again for joining us.